Hi, and welcome to this session on wound assessment. I apologize for the voice. Here's an overview of the teaching goals. We're going to build a strategy for differentiating between the types of wounds that we will encounter. We're also going to look at when to suspect arterial disease and when to suspect venous disease. And we're also going to look at the questions that are important to ask the patient and the assessments that we should be able to do bedside or at the clinic, and also when we should consider referring the patient to a hospital or a specialized center. I'm assuming you all have seen these wounds, and whenever you notice a wound, you'll immediately start thinking, could this be venous? Could it be arterial? Does the patient have diabetic neuropathy? And these are common sites for venous, arterial, and diabetic neuropathic wounds. The venous are usually or almost always located above the ankle, and sometimes they are circumferential, meaning that they go all the way around the leg, the whole circumference of the leg. Arterial disease is mostly located down on the foot, but could also be on the anterior part or around the middle part of the ankle. Whereas the neuropathic, the diabetic neuropathic, they have their trigger points, so pressure points, such as under the metatarsal head, here on the side where a shoe might knot at the skin, here by the malleolus of the ankle, and especially underneath the heel, is where you see these neuropathic wounds develop. Here are a couple that we're going to talk about. Here we see these circumference, the whole circumference of the leg, so you start thinking venous. Here, pressure point by the metatarsal, immediately start thinking of diabetic wounds. And this could be a combination, or it could be strictly arterial, but we'll look into these. What I want you to just keep in mind, but this is not going to directly affect your diagnosis, but I want you to just keep in mind that 75% of wounds on the lower extremity are located on the level above the ankle, and 25% located around the ankle or the foot and or the toes. Wounds that develop in this area right here are in 70% of the cases venous, whereas only 10% are arterial, and it could be a combination or others that we're going to get into. Whereas wounds that develop down here on the foot are 50% of cases arterial and 25% diabetic, and only about a few percent are venous, and they are usually located high up on the foot right here. And we'll get into the others that could be possible causes. So let's look at the systematic approach. This is really important and should be done in any patient that comes in with a wound. We're going to first gain information about the wound itself, then about the patient. So what the patient brings to this in terms of age and comorbidity and so on is really important to give us a clue as to how probable it is that we will get this wound to heal up. We'll look at the patient's symptoms leading up to the wound and other circumstantial things that might prevent healing, such as mobility and so on. And then we're going to look at the basic tests that are available and how we assess going on to get our actual diagnosis. So we start with the wound. We look at the location, so examine every part of the leg and the entire foot to look between the toes. You're going to describe the size by measuring the wound. You're going to describe the depth and the edges of the wound, and also any smell, any fluid coming from it. Does it bleed? Is there granulation or signs of healing? Also ask the patient for the history of the wound itself. When did it occur? How did it spontaneously occur? Did it appear after a small trauma? or did the patient not notice at all? Did someone else notice that the wound was there? Has there been other wounds that have healed that have been similar? And that could be a good indication that we might be able to get this wound to heal too. And also, what is the tissue surrounding the wound like? Is this a huge area of edema? Is there pigmentation or changes in the skin, or is it just an isolated wound in itself? Then we look at the patient. First, we look at the general condition and the age. So if this is a very young patient that is in great condition and has had a wound for a little while, it might be fairly simple to diagnose and to treat. Whereas if this is an older patient in a fairly poor condition, then and that has chronic illness, this might be more of a challenge, and that's more typical of the type of patient that you might see in the clinic. We're also going to look at the chronic illnesses that the patient has, especially cardiovascular, kidney disease, diabetes mellitus, and I'm going to put 2 lines under that because I'll be talking a lot about diabetes mellitus. They have a much higher risk of chronic wounds and amputation than the average person. Also, ask the person about previous treatment. Have they had any stenting of their blood system, their cardiovascular system? Have they had any surgery on their leg? Especially, let's say they've had fractures, or they have metal inside their leg, or something has happened that makes them more vulnerable to wounds. Have they had other wounds that have healed? Also look for or ask for a deep venous thrombosis, because that's important in assessing venous disease, because that increases the risk of post-thrombotic. I mean, a patient that has undergone a deep venous thrombosis might have a post-thrombotic syndrome, in that they have increased venous pressure in their foot. And finally, smoking again and again. We look at the symptoms that the patient has. Is there any pain? Are there any signs of infection, local or systemic? And you should think venous disease if the patient explains that, or if you can see the edema, or if the patient complains of heavy legs, or if you see varicose veins on the legs. And you should think arterial disease if the patient complains of intermittent claudication, meaning that they will tell you for years they've had the problem of leg pain whenever they walk, maybe anything from 100 to 500 meters. They will feel that the leg tightens and they have to stop and rest for a couple of minutes. And that's an early symptom of arterial disease. Also, we're going to look at you should examine the circumstances surrounding the patient and the wound. What about immobility? Is this a patient in a wheelchair? Are they bedridden? How's the blood control level been, especially for those with diabetes mellitus? Are they malnourished or even undernourished? That's really important, because a wound won't heal if the patient is malnourished or undernourished. And just make up your mind in a general sense. Is this a patient that should be hospitalized? Should all of these examinations or this diagnosis be done in a hospital where they can get better nourishment and maybe even treat other diseases? So when it comes to the basic assessment, you should always palpate pulses. You should do an ankle brachial index. You should test the sensibility of the skin, doing a prick test on the foot to see if they feel anything or if they have neuropathy, so that they can't feel that they maybe step on something sharp and it punctures a hole in their skin on the foot, especially typical for people with diabetes mellitus. You should evaluate the footwear and look for pressure points, especially people in wheelchairs and bedridden patients. They might have pressure points on the skin that can cause wounds. And when it comes to advanced assessment, if you suspect venous disease, it's fairly simple and straightforward to do an ultrasound color duplex, and that should be considered. And there are very few instances where you should not give the patient compression stockings almost all patients can benefit from compression stockings. The only ones that should not have compression stockings are people with very low ankle brachial index or advanced arterial disease. So if you suspect arterial disease, ask for intermittent claudication symptoms. If you can't find any pulses, or if they have a low ankle brachial index, especially those under 0.5, you should definitely suspect arterial disease, and they should be referred to a vascular surgery unit in order to do the necessary examinations. And that should, in almost all instances, be a MR angiography. If the patient has a wound and they have diabetes mellitus, we also almost always do an MR angiography, or we sometimes do what's called a direct or a digital subtraction angiography, where this is an invasive technique where we puncture the femoral artery and then we do a contrast examination, and the benefit of this is that we can do any type of angio treatment. So we can treat the patient while we're still inside the artery, but in almost all cases we want to get what we call a roadmap. We want to map out the vessels or the arteries of the patient. So we do an MR angiography. Here's just an overview of the advanced assessment that we can do. Almost all hospitals, even some small outpatient clinics, or even some of the family doctors might have ultrasounds, and that's a gold standard for looking for venous disease, so especially reflux disease. MR angiography for suspected arterial disease, sometimes CT, but that's only used if the MRI is not available, or if the patient has previously undergone stenting and has metal that might give you a false positive stenosis in the artery, because the MRI will look at that metal and consider it to be a disease of the artery. So that's why we sometimes do a CT when people have undergone stenting in their arteries. A lot of hospitals, but not all of them, have the ability to do a toe brachial index, similar to an ankle brachial index, but the toe brachial index has a normal level of 0.7. Usually 0.5 will give you an indication of reduced arterial circulation, and a 0.2 is usually the level of critical ischemia. You can also do a pulse volume registration. This is not a pressure registration, it's more of a volume registration of the flow below the knee and down to the foot. You can also do micro circulation examinations, combination of laser Doppler registration and look at the transcapillary oxygen saturation. And these are more advanced and are usually at highly specialized centers. So these, especially the last two, these ones here are more at the specialized center. Some of the hospitals do have toe brachial index. That's become more and more common in a regular vascular surgery department. Other types of wounds, here I'm looking at the typical ones. Traumatic wounds, very typical among younger patients, but they can occur at all ages. And just consider this, that even if you have a frail old patient, a traumatic wound might heal by itself. So you should try to have spontaneous healing of traumatic wounds. But if the traumatic wound will not heal, then you should consider underlying conditions such as venous disease, diabetic neuropathy, arterial disease, or so on. Pressure wounds or ulcers are difficult because elderly patients in institutions are high risk, and patients with neurological impairment, people in wheelchairs, and people who have neurological impairment in the sense that they don't feel that they develop pressure wounds. The only way that you can treat this is by alleviating what causes the pressure, and that can be really difficult in a patient that is bedridden or in a wheelchair. And then Other wounds that are atypical are, of course, malignancy and vasculitis. So here, I just want you to consider that if you've done the local treatment, and even if we've done interventions on the arteries or the veins, and the wounds will still not heal, then you should consider a biopsy and think malignancy or vasculitis. You'll see in some books that that will tell you that if the edges of the wound is elevated, that that you should consider malignancy, but that in and of itself is not that secure. What I want you to do is, if a chronic wound won't heal despite local treatment and even intervention, then you should think malignancy or vasculitis and consider doing a biopsy or have the surgeon do a biopsy. All in all, I just want to say that the best approach, and study upon study has shown this, and we talk about this in all international meetings, the best approach for dealing with any patient that has chronic wound is a multidisciplinary team. Diabetic foot teams, arterial and venous disease teams, and so on. But the best approach for any chronic wound patient or patient with a chronic wound is a multidisciplinary team. At the very end here, I would just like to show you 2 examples. This is a patient where you have asked all the right questions. You start by asking about the wound itself, and what you see is this: you have pigmentation, the whole circumference on both sides, and they're above the ankle, so above the ankle, and you have some wounds right here. There's one. This patient tells you that they've had chronic edema for many years, and they've had pigmentation, so this discoloration for years. He's had a previous deep venous thrombosis in the right leg, and then you ask about the symptoms, and that heavy legs and maybe some itching, and other than that, the patient does not smoke. The patient has no diabetes mellitus. You do an ankle brachial index, and it's 1.0, and a good pressure. It's a very good pressure of 140 millimeters of mercury. So what do you suspect? And yeah, that's right. You suspect a venous disease. You suspect either a deep, because of the former or the previous DVT. You suspect that he might have a post-traumatic syndrome, or there is a superficial reflux in the venous system, and so you refer the patient to an ultrasound, and you find a superficial venous reflux on both sides here, and you can see some varicose veins, and this patient has superficial venous reflux and is treated for that. Good. Now let's look at the second one. This is a patient I had in the hospital years ago with diabetes mellitus, poorly treated, heart disease, and he was smoking. This is important also. The person had no pain in the wound itself. So in this area right here, no pain. And as you can see, you have some necrosis right here on the tip of the toes, which you should suspect arterial disease, of course. And you know the patient has diabetes mellitus, and you can tell here by the head of the metatarsal, you see a wound develop that has become somewhat infected, and you have some skin changes, so we have colored up right here. But the patient has pain in the leg and the foot during rest, so he feels pain in the leg, giving you somewhat of an indication that this could be arterial insufficiency at a critical level, and the wounds might be caused by a combination of the diabetes mellitus, the neuropathy, that should trigger the suspicion that he doesn't have any pain in the wounds themselves because of the neuropathy, but pain in the leg because of poor arterial circulation. Infection was prominent, and the patient was malnourished. There were no palpable pulses below the groin, so you felt some pulse in the femoral artery, but below that nothing. and we could not measure the ankle brachial index. We didn't get any signals. What happened to this patient is we tried to intervene. He had a lot of arterial disease in the foot, the whole arcade, the microcirculation was poor, and also up on the leg, also above the knee. Tried several interventions. The patient ended up with an amputation, and finally amputated on the level of the thigh.